80 million, 85 million, 85 million human rights investments across the region. In the Asia Pacific region, we have about 11 to 12 million investments going to human rights programs in the context of HIV. And then around 4 to 5, maybe maximum 6 million if we really take all the integrated investments, then going to human rights programs in TB. So as you can see, in terms of the grant size, these are not huge investments. I think it's less than, for HIV, it's less than 2%, and for TB, even less, it's less than 1% of our investments going to these critical programs that will contribute to creating enabling environment. And as you can see, majority of programs are going to the working with the health facility care, healthcare workers, and stigma reduction efforts and legal literacy. So wide range of the programs. But as we heard from the speaker from Nepal, Recovering Nepal, our investment in legal literacy or increasing access to justice or the legal reform, which takes long period, it's a long-term goal and heavy investments for the advocacy, has not been really met to be at the scale to be effective. So we have a lot of long way to go, despite the great progress we are collectively making. Can you move to the next slide, please? So now I want to discuss some of the opportunities. By now, and since you're joining the 7 Alliance webinar, you should be familiar with the community engagement strategic initiative. But I want to highlight again how important it is. Global Fund can only fund the programs that are in the funding request. And as you know, in order for us to develop a robust funding request, we have different mechanisms. Country dialogue is one very critical mechanism where we encourage involvement or engagement from the communities. But I understand, and we understand, that sometimes it is really challenging to really engage in the community dialogue or the CCM meetings. We may not have enough information. We may not know how to frame such things in the Global Fund language. We have different the technical assistance or the long-term support that can really support your engagement in the Global Fund processes. I know Niluka is coming in later to really hone into some of these points, so I will not go into the details, but I just want to highlight some of the important, maybe most critical components, in my view, is really the component 1 on short-term technical assistance for the community mobilization. I see in the Asia Pacific region, we have not really taken advantage of these components. This is a short-term peer-to-peer led technical assistance to really allow you to do your community consultations, to really tell us what needs to be done for the communities, by the communities. And that needs to be included in the funding request. I really hope, especially for the TB and malaria communities, to really take this opportunity of available funding for the technical assistance to do your community engagement and let us know what needs to be done for your communities through the Global Fund investment. Next slide, please. So this is not the Global Fund specific initiative, but I thought this, given the context of closing civil society space in many countries, I mentioned to you Vietnam, but also Sri Lanka and many other countries, I thought this could be a good opportunity. So Global Fund, we have been working closely with Thomson Reuters Foundation. Thomson Reuters Foundation, within the Breaking Down Barriers initiative, supported various different trainings and for the youth advocates in the context of HIV, TB, malaria, etc. But in addition to that, Thomson Reuters Foundation also supports Trust Law Project. So what does it provide is really a free legal health check for the civil society organizations to really make sure that your structure and your legal framework is really are within the context of national law. It can also support legal research. So for instance, if you want to understand how does the, like for instance, the laws and policies in relation to the drug rehabilitation impacts the HIV services or impacts my community, they can support law and policy analysis or the research. And they can provide legal trainings, and they have different tools and resources that you can use for your communities and your organization. You have to, I also provide a link in the presentation slide. You have to join the network. I have actually gone through the process of joining the network. It's a really simple process, but it's basically registering your organization in the network. Then you can already access some of these the free services that are available through the trust law. If you have any, if you need any help or the information on the trust law, please do contact me. I do think this is an important opportunity that we can all really tap into. I think that is the last, next slide, please. I have one last slide just to show you the different types of guiding materials that we have for the applicants. Today, I only focus on the human rights investments, but we know that human rights investments alone, human rights programs alone, does not make a comprehensive and robust funding request. We need to focus on gender equality. We need to focus on the community system strengthening. We need to focus on various other elements that really make the HIV/TB response work in your context. So these are some of the technical, the briefs that we are providing. And if you need further information on any of these or any of my presentation materials, please do get in touch with me directly. I'm very, very open to get to know you. Thank you very much.
Thank you so much, Hye-young, for reflecting the Global Fund approaches. Now we are opening the floor for the questions from participant. Kindly raise your hand or write in the chat box, requesting participant to keep the question short and precise. Hye-young, there is one question from Musrat in the chat box. Why Global Fund does not include migrant workers as a key population to support for their HIV and AIDS related issue and raise awareness on preventing HIV among migrant workers? Within our limited resource, CAREM Asia has done HIV testing on of returnee migrant workers as well as in receiving countries and have found HIV positive cases. Hye-young, would you like to take this?
Thank you. That's really great question. Thank you so much for that. So let me just start from the definition key populations. So Global Fund, we developed the key populations action plan, I think in the beginning of the launch of the new funding model. We have a criteria for the key populations, and that also includes not only the disease burden, but also the legal framework, the criminalized populations. For migrant workers, we do recognize in many contexts, the HIV burden is high among the migrant workers. And also if you're undocumented migrant workers or mobile population, the access to HIV or other health services are really impaired. So in many countries, in fact, we do, even though migrant workers are not included in what we call generally the 4 key population HIV, but in many contexts, we do support HIV services for the migrant workers. I think Nepal is one great example where really scaling up the investments for migrant workers or mobile populations in the context of HIV, TB, and malaria. But really great question. Thank you.
Thank you so much, Hye-young, for answering that question. Manoj Pardesi from India wants to raise his question. Manoj, the floor is yours.
Yeah. Hi. Thank you. Thank you, everyone. Lim, thanks for very wonderful presentation. Especially the slide where you mentioned that Global Fund is investing in human rights, stigma, discrimination, and everything. Even since last more than 6 years, like last 2 cycles, Global Fund is started talking about CSS and CLM. My basic question is, besides huge strategic direction, besides the money allocated for CSS, CLM, human rights, stigma discrimination, why it is not reaching to the community? And I guess this question, like all other participants, will also share their country response. At country level, it is not reaching to the community. And what is the parameter which Global Fund looks when you see that so much money is allocated for so and so purpose, and it is not reaching directly to the community, but it is just with the government or with some international agency who is actually getting the use of that money.
Thank you. That is a great question and very difficult question to answer. And I fully understand your perspective and where you're coming from. And to a large extent, yes, it is true. Our principal recipients or the sub-recipients are the government partners or the larger civil society organization, or some are international organizations, UN organizations. However, we do push for the community-led service delivery and responses. So with the CSS investments, we are hoping to be able to support community system strengthening in order for the communities to be able to deliver the programs. And then, of course, community-led monitoring is another mechanism to really monitor how the services are delivered, the quality, the quantity, availability, accessibility, and the quality of the services that should be monitored and led and monitored by the communities. So your question, and despite all these investments, why these are not reaching the community-led organization? I think we do need to really look hard on our implementation arrangement, how we are really fostering the community leadership in our implementation arrangements and working with them. But we do have in the Global Fund key performance indicator that actually commits us to kind of attract the engagement of communities and civil society in the Global Fund program implementation. So with the due time, we are really hoping to be able to work a little bit more closer with the communities directly and have the funding flow more to the community and civil society organizations. With that, we have, in order to support that effort, we have launched a new initiative called Community Pools. Of course, Community Pools initiative is only available, regretfully, only a handful of the countries, I think only about 11, 20 countries, 11, 12 countries can benefit from this initiative. But through the initiative, what we aim to do is really want to support the core capacity building of the community-led organizations, community-based organizations. I think the core capacity, financial management, governance structure, whether you have the right organization of policies and structures and leadership, I think that is sometimes a hindrance to receiving the donor funding or engage in the social contracting. So through these initiatives, we are hoping to really support building the community core, the capacity building of those community organizations. But I fully understand your concern, and this is our concern too. And I do believe this is a greater piece, but please rest be assured, we do understand, and we are really hoping to work with you on how we solve this challenge. Thank you.
Thank you so much, Hye-young. Apologize to everyone due to our limited time. We have to close our Q&A session, but I know that we have lots of questions. You can email to the 7 Alliance email. Now moving on to our next session, that is panel discussion. And to moderate this session, I would like to invite Ika Novianti, Regional Coordinator at YouthLead. Ika, over to you. Thank you.
Thank you so much, Karon. Hi, everyone. As Karon mentioned, my name is Ika, and I will be the moderator for this panel discussion. Welcome to our panel on bottleneck and challenge to integrate human rights intervention into GRAN. So due to interest of time, I would like to call our panelists. We have 4 amazing panelists for this discussion. So first panelist is Wulan Surani or Nana, the Program Manager of Organisasi Perubahan Sosial Indonesia, OPSI. As a program manager at OPSI, she leads vital initiative in program development and organizational networking. Her work focused on empowering vulnerable population, particularly in healthcare access and legal rights for female sex workers. Welcome, Nana. The second speakers, I would like to invite Siripim Pibonwah, CSO platform, as the Monitoring, Evaluation, Accountability, and Learning Officer. Siripim brings valuable expertise in community health monitoring and evaluation. As a male officer, she lead initiative in community-led monitoring of malaria prevention and health services. Her work focused on enhancing health equity and accessible healthcare for marginalized community through data-driven and collaborative approach. The third speaker, we have Rosie Amian, Senior Program Officer, Regional Artemisinin Resistant Initiative Grant of the Global Fund. Rosie is a Senior Program Officer at the Global Fund with over 20 years of expertise in the global public health. She currently manages the Regional Artemisinin Resistant Initiative for malaria elimination across 5 countries and oversees Myanmar's HIV/TB portfolio. Last but not least, we have Niluka Dilshan Pereira, the Community Engagement Strategic Initiative, CRG Department of the Global Fund. Niluka is the Senior Program Officer at the Global Fund Community Rights and Gender Department, Community Engagement Strategic Initiative. And previously, he works with the Global Fund Advocate Network ASEAN the Pacific as the advocacy program and the coordination officer. So welcome to all our panelists. First question I would like to direct to Nana. So Nana, what are the challenges you face as a young sex worker for accessing the health services? And also, is there any human rights intervention to support sex work within the organization supported by the Global Fund? Over to you, Nana.
Baik, terima kasih Kak Ika atas pertanyaannya. Apakah suara saya terdengar? Kedengaran?
Yes, loud and clear.
Oke, menjawab pertanyaan dari Kak Ika. Jadi untuk kawan-kawan di Indonesia khususnya sampai saat hari ini, tantangan yang masih dialami oleh kawan-kawan pekerja seks perempuan khususnya di populasi kunci muda, yaitu kawan-kawan berusia muda dari di bawah 25 tahun. Yang pertama, bahwa kami mengetahui tingkat literasi kesehatan kawan-kawan pekerja seks perempuan muda itu sangat minim sekali tentang kesehatan reproduksinya. Ini diambil dari beberapa asesmen yang dilakukan oleh kawan-kawan Indonesia. Jadi ada asesmen dari INPI Muda, dan kemudian yang satu adalah dari PKBI DKI Jakarta yang melakukan asesmen dasar atau asesmen singkat terkait dengan tingkat pengetahuan kawan-kawan pekerja seks muda di 7 provinsi di Indonesia. Nah, kemudian yang kedua adalah bagaimana pembatasan akses terhadap layanan kesehatan itu. Yang pertama adalah untuk khusus di wilayah-wilayah terpencil, akses ke layanan kesehatan itu jauh.
Nana,
Ini misalkan
so sorry,
seperti di wilayah-wilayah Jawa yang ujung, kemudian wilayah Papua, kemudian wilayah-wilayah pulau yang cukup jauh dari ibu kota provinsi, itu sangat jauh sekali aksesnya, dan itu membutuhkan biaya yang cukup mahal. Kemudian ditambah ketika kami bisa mengakses itu, keterbatasan kami dalam mengakses logistik itu cukup susah. Pertama khususnya adalah di kondom, kemudian pencegahan KB. Ketika kami mengakses
Nana,
KB, kami
could you
ditanya
please pause for
apakah
a minute?
Yang pertama adalah identitas penduduk kami itu statusnya menikah ataukah tidak. Ketika kami masih lajang atau janda,
Hai, Nana.
itu kami sulit. Ya.
Sorry, di pause sebentar ya, soalnya Agatha nge-lag dia.
Oke.
Apologies everyone. The interpretation seems like having.
We can, but there seems to be a bit of lag from your end when the interpretation starts.
Okay. Agatha, could you please like translate after Nana speak? I think that would be better because the translation is like cool. Sorry. Nana bisa mulai lagi ya?
Dari awal.
Yang setengahnya. Yang waktu KB. KB.
Oke. Jadi pada saat akses ke layanan Vaskes itu bisa kami datang, kami bisa hadir ke sana. Keterbatasan kedua kami adalah untuk mengakses logistik atau misal contoh konkretnya adalah kayak KB, layanan KB itu kami harus dilihat dulu identitas KTP kami, apakah sudah menikah atau belum. Ketika belum atau statusnya janda, kami akan dibatasi untuk bisa akses layanan tersebut. Gitu. Kemudian ngomongin tes IMS. Di ruang lingkup IMS, keterbatasannya adalah kami ada beberapa puskesmas atau layanan kesehatan utama yang menyediakan tes IMS, namun tidak semua. Dan saat ini beberapa layanan HIV itu hanya menyediakan untuk tes HIV. Untuk tes IMS kami harus memilih layanan-layanan primer yang itu menyediakan tes IMS. Ditambah lagi angka IMS pada teman-teman pekerja seks perempuan itu sangat tinggi di Indonesia. Namun ketersediaan obatnya itu benar-benar sangat terbatas. Nggak semua puskesmas itu menyediakan obat IMS. Kalaupun ada, itu jarang. Kemudian ditambah ketika nggak ada, di apotek ada, tapi biayanya sangat mahal. Menurut kami ya, di angka 100.000 saja, itu bagi kami sangat berat untuk kami bisa mengeluarkan itu. Sedangkan pengobatan IMS itu rentangnya sebentar, nggak dalam waktu yang lama gitu. Sekali beli itu hanya diminum 1 minggu. Minggu depannya lagi harus periksa lagi. Itu keterbatasan soal logistik di ngomongin isu pada pekerja seks perempuan muda. Kemudian yang dari komponen-komponen ini yang kadang merasa bahwa kenapa kami harus pelayanan kalau misalkan percuma nanti kita dapat tes tapi obatnya nggak ada. Kalaupun ada nanti belinya di luar selain dari layanan kesehatan primer gitu. Harus beli, harus biaya mahal. Belum ditambah lagi biaya ongkos bolak-baliknya kami juga mahal. Ditambah kalau kami harus ditanya, KTP-mu belum menikah, kenapa kamu akses? Kemudian kami harus ketika konseling pun kadang kamu masih muda, kamu masih bisa sekolah tinggi, kamu masih begini kok sudah bekerja sebagai pekerja seks. Dan itu sangat membosankan ya ketemu dengan berulang kali serangkaian orang yang menanyakan dengan atau melakukan konseling dengan pertanyaan-pertanyaan yang serupa. Itu masih itu yang menjadi saat ini sering menjadi tantangan utama bagi kami dalam mengakses layanan kesehatan. Kemudian
sebentar ya.
Ini poin tambahan terakhir terkait dengan bahwa di Indonesia itu masih undang-undang saat ini tuh mengatakan bahwa seseorang berumur di bawah 18 tahun itu dikategorikan sebagai anak. Ketika dikategorikan sebagai anak, ada undang-undang lain, yaitu adalah undang-undang kesehatan. Ketika seorang anak mengakses layanan apapun itu, maka diwajibkan ada pendamping. Dan beberapa puskesmas untuk akses layanan HIV memang sudah memperbolehkan kami didampingi oleh petugas lapangan, petugas penjangkau, itu diperkenankan, tapi belum menyeluruh. Kalau dipresentasikan di wilayah Indonesia, angkanya nggak sampai 50% yang bisa mengiyakan, memperbolehkan kami PL itu jadi pendamping kami. Ditambah lagi, ketika ada kawan-kawan pekerja seks perempuan muda yang mengalami KTD, pendampingnya itu diwajibkan adalah suaminya, bukan orang tuanya. Sehingga ini sangat-sangat membatasi bagi kami, bagi khususnya pekerja seks perempuan muda, untuk memilih, kami punya hak untuk tidak melanjutkan kehamilan kami, karena kehamilan ini tidak kami inginkan atau lain sebagainya. Itu tantangan yang saat ini dihadapi oleh kawan-kawan pekerja seks perempuan muda di Indonesia.
Oke.
Terima kasih Kak Ika.
Terus di situ dulu ya, Nak, biar Agatha translate sebentar. Agatha,
Kecepatan.
okay. Agatha, do you want to translate? Go ahead, Agatha. Thank you so much, Agatha. Nana, do you mind to share the intervention support by the Global Fund?
Ya, terima kasih Kak Ita. Untuk saat ini, memang Global Fund mengintervensi ruang lingkup pengurangan stigma, pengurangan hambatan khususnya ya, yang di dalamnya adalah pengurangan stigma dan diskriminasi. Ini hasil dari pengukuran kami di opsi bahwa memang sudah terjadi pengurangan stigma dan diskriminasi di tingkat layanan kesehatan, tapi tidak spesifik ngomongin yang dialami oleh PSP dari semua populasi kunci dengan rentang 1 tahun, 2 tahun pelaksanaan program itu dari 22 sampai dengan 23, angka penurunannya itu sekitar 40% di layanan kesehatan. Nah, itu intervensi yang sudah terlihat perubahannya. Namun ada gap yang menurut saya masih perlu diupayakan lebih lanjut, ngomongin tentang tadi perihal perubahan kebijakan gitu ya, yang tadi saya sebutkan untuk intervensi PSP muda. Memang perlu ada upaya yang benar-benar konkret untuk perubahan bagaimana bisa di semua wilayah dapat mengakomodir kebutuhan ketika kami mau mengakses HKSR gitu, hak kesehatan reproduksi kami. Jadi bisa mempermudah kami mengakses itu untuk mengatasi tantangan yang ada. Dan kemudian yang kedua adalah bagaimana Global Fund ini selain memprioritaskan HIV-nya, juga memprioritaskan isu pencegahannya, ngomongin IMS-nya. Bisa mendorong atau mendukung bagaimana tersediaan logistik maupun kualitas dari si layanan IMS di layanan-layanan primer di Indonesia. Yang terakhir adalah tentang stigma dan diskriminasi itu sendiri. Kalau di cycle sebelumnya itu Global Fund menyediakan dana untuk membantu populasi kunci yang mengalami kekerasan baik di layanan kesehatan maupun non layanan kesehatan. Namun untuk saat ini itu nggak ada. Sedangkan itu masih dibutuhkan karena temuan angka kekerasan bahkan setiap tahunnya itu selalu meningkat, khususnya pada pekerja seks perempuan. Itu yang juga perlu untuk diintervensi ngomongin. Terima kasih Kak Ika.
Thank you so much, Nana. I put the interpretation in the chat box so you can see what is the intervention from Nana shared before. So now I would like to call Siripim. The question is quite similar with Nana. So what are the challenges malaria-affected community face accessing the health services? And also, is there any human rights intervention to support communities with the support of the Global Fund? Over to you.
Thank you, Ika, for your questions, and thank you for having me today. For the CSL platform, as we are working in the malaria health services, and our target mostly is the community along with the cross borders. So today I'm going to highlight about on what we have found from our finding that we went to the communities. But for today is the case example for the Thailand that we just went to the field. And the most challenges that the community highlights that they have been faced related with the human rights. The first one is about the discrimination. So most of them share that, for example, if they are going to the health center to receive the health services, is like most of them receive the delay response or the services from the health staff or for the health center is because of it's quite take time for the staff to do the document, to review the document or to prepare those documents. And sometimes it's because of the languages that they are communicate in different language. And some health center, they do not have like an interpreter. to help them to coordinate with those group of the people, or SMS the migrants group or those marginalized group that they don't have anyone to help them to communicate in the local language as well. So in this situation, it pushed like a health staff prioritize the local citizen first, even those marginalized group or those the group of people they arrive first. And for this part, I think it's kind of the gaps and issue may increases the vulnerability to those migrant and marginalized people, and also it's make them hard to accessing to the service. Okay, and the second point is the issue that related with the gender equity or the gender-based violence. So this point from my point of view is very important as well, because of the community along the cross borders, they have like a diverse the social norms. So for example, in those community, the women, as you know, that most of the women they are assigned to only most on the household work, and they are lacking of the decision-making power to do something or to do anything, that they have to follow the command or follow the decision for the head of the family. As we know that mostly is his husband or his father. And this point is, as I said, that is very important, because when they would like to go to the health center where they have like a health issue, where they have sick, not only them or maybe their children, their mother or any member in the family, so they can not make the decision at that time or immediately to spend the money or to choose to go to the health center. So I think this dynamics plays the high or increasingly to the women as well in terms of the gender equity. And this is not, for me, this is not for the malaria as well, but also affect to those health issues or other disease. Okay, and for the third one is about the gaps, the policy gaps or the gaps in the domestic laws, that you know that most of the domestic law or the policy right now are not cover the migrant people, especially who are undocumented migrants, that quite hard for them to find a way or ask the support for the health center or go to the health center. And this point also affected to the stateless children or the young people that who are not registered. And yeah, because if they have the problem or they have something that need to ask for the support, so it's hard for them to access to the health services. Yeah, and additionally, from our point, from our perspective, one of the things that we see it still have the gaps is about the voluntary consent. As you know, when we went to the community, when we go to the community, we have to interview the people, or when we have to do the case investigation, we have to ask the consent from them. And the gaps is that, for example, for the case investigation from malaria, when we file the case, and we have to go to that people, right, to investigate and ask the information for them. Sometimes in case of that urgency, we are pushed to do the case investigation, and sometimes it makes those people, those person or those patients feel like get pressures, because there are many questions that they have to answer, and we have a lot of the question that need to ask them, and sometimes they have to give the consent without not fully understanding or not ready at that time. And we have to concern that, because the disease is the issue of the community, of the community, and some people feel like it's stigmatized or pressure because the other people in the community will see them as maybe like a potential risk of the community as well. And for the intervention, right now CSO platform, we are develop the CRM for the malaria, and we just start piloting in the province in Thailand. That we see that the CRM is the tools that empower the community to help us to decrease the gap of the health services, because we can see the perspective directly from the community, that they can share what is the barriers, what are they struggle with, and what we as malaria workers in every sectors can help together to improve the health service in the community. Thank you.
Thank you so much, Siripim, for highlighting the crucial issue of the delay and also interpretation challenge in the healthcare services that faced by community. So let's move to Rosie. So Rosie, in your experience working with malaria, have you ever witnessed human rights inequalities toward the migrant and rural indigenous population in the region? And have this challenge been addressed? And also, what are your recommendations for this? Over to you.
Hello, good morning, good afternoon, everybody. Thank you very much for the question and the invitation. I'm happy to follow on from Sirimpim, who works on the CSO platform. I'm a program officer that works on the RAI grant, which is a multi-country grant across 5 countries in the Mekong, supporting them to achieve malaria elimination. This is in Cambodia, Laos, Myanmar, Vietnam, and Thailand. In these areas, malaria is mainly among the forested areas and the border areas. And typically this is among populations that are mobile and migrant in nature, moving across border areas, but also working in the forests. So by the very nature of the disease and how it is found geographically, these populations have less access to healthcare. There's less formal structures in these areas. And in addition, Myanmar, which is one of the countries under the grant, faces additional challenges with ongoing conflict, which further isolates populations, increases mobile population movement, and therefore also increases the risk of not only getting malaria, but reducing the access to care further. When I was started, the architecture of the grant and how the grant was set up was designed to try and meet these challenges. One of the key purposes of this, or one of the key ways this is done, was by earmarking funding to maintain and ensure that a high level of funding was earmarked and secured to use for these particular populations. And that was done using a regional component. We've also continually strongly urged countries to make sure they maintain high investment in civil society organisations and NGO involvement as well. And to overcome the challenges to access to healthcare, there's been a very high investment in community-based service delivery. So there's been over 40,000 community health workers that have been routinely invested in throughout the programme. This is reduced slightly due to the reduction in malaria burden, but this is over 27,000 now in the existing grant. And community-based testing and treatment remains one of the major ways of detecting malaria across these 5 countries, with over 75% of malaria being tested and treated at community level in a number of the countries. Tailoring approaches even within the community has also been really important. With mobile populations, it's also really important to have mobile community health workers. We've got mobile community workers. We've also got forest packs that are provided to forest workers, which include hammock nets and other specifics for them that can be helpful in terms of preventing malaria. While we've been able to overcome some of the challenges through the design, we've also needed to maintain a very high focus on community and civil society organisations. And one of the other areas of the grant and the way that the grant was set up was to include the civil society organisation platform, which you've just heard about. Putting this in the architecture of the grant means that irrelevant of what happens, there will always be a voice for civil society organisations, and it also allows for this platform to deliberately and mindfully go and seek information from communities to help tailor the grant, and also always make sure that there's high representation at the regional steering committee level. While we've overcome many of the challenges, or at least designed the grant to address some of the challenges, there will always remain challenges. The recommendations that I would have are to make sure that the investments remain in the right place. In terms of the grant that we're looking at, this means that we maintain high investment in civil society and CBO organisations that are able to provide testing and treatment at a community level. This will always be important. In terms of sustainability and transition, we also need to look at the integration of community health workers. While these populations don't have access to malaria treatment, they may also not have access to other healthcare services. So integration of community health workers is imperative to make sure that they can have access to other healthcare services. One of the other recommendations I would have is that communities and contexts are dynamic, but don't assume that the realities are static. Maintain community-based assessments. Use the information from communities themselves to feed back into the design of programmes. A gender assessment last year conducted by the CSO platform in Laos identified that while we're focusing a lot on men and malaria in the Mekong areas, there's a lot of barriers to women getting access to treatment, specific barriers that need to be addressed. And lastly, increasing meaningful involvement of the communities. We've just heard Srimprim talking about community-led monitoring. It's been a challenge to develop these tools for the malaria context where they've not been used highly, but it is really important that we keep pushing forward with that to identify how communities can increase their ownership and their voice and design in the future of malaria in their communities. Thank you.
Thank you so much, Rosie, for highlighting those important work that you have been doing. Last but not least, I want to move to Niluka. Niluka, what are the technical support opportunities available for community engagement to integrate human rights intervention in the region? Over to you.
Great. Thank you so much. And thank you so much, Roshi, and all the other speakers for all the interventions for this panel. As we understand, as Hye Young mentioned at the very beginning, human rights is at the core of the Global Fund strategy. And as communities and civil society, human rights is at the core of what we do, because what we want is acceptable and accessible services to communities and civil society who are affected by the 3 diseases that they can access without fear, without being discriminated. And for this to happen, we really need to make sure that voices of communities are heard and heard at the decision-making levels, and that we work with all the stakeholders, including the Global Fund and also national stakeholders, to ensure that we maximize the very limited resources that we have for this work. So I'm going to talk to you about the Community Engagement Strategic Initiative that provides technical support for communities and civil society to mobilize and work around Global Fund and related processes at the country level to ensure community voices are heard and incorporated into decision making. Give me a minute to share my screen. Okay, I think you should be able to see my screen now. Great. Okay. Going through this quickly. Okay, so the objective of the Community Engagement Strategic Initiative is to strengthen leadership and engagement of communities most affected by the 3 diseases in Global Fund and related national processes throughout the grant cycle. And the whole idea is to improve the impact of Global Fund investments. So at the end of the day, what we want to do and see is that the investments of the Global Fund has higher impact as a result of strengthened community engagement. The community strategic engagement, Hye Young also showed this as 3 components. Component 1 is short-term technical assistance, which I'm going to talk to you about today. And it also has long-term capacity strengthening, a component and learning hubs, of which Asia Pacific Learning Hub hosted by 7 Alliance is one of them. When you look at the outcomes, what we want as a result of these 3 components and our investments is communities generate and use data to influence decision making. Communities have capacity to mobilize and hold their representatives accountable. Communities have timely and relevant global fund information to ensure that their engagement is strengthened. And lastly, communities drive program quality based on adoption of global guidance. As a result of these outcomes, the catalytic effect that we are expecting to achieve is strengthen leadership and engagement of communities affected by the 3 diseases, global fund and related national processes. And as a result of that, through engagement in the ground cycle, we have improved impact of global fund investment. So everything is focused on improving the impact of global fund investment and our work as communities and civil society with the global fund. So what is short-term TA? Short-term TA allows us to support communities and civil society at the country level to mobilize and to engage in diverse decision-making platforms to influence decisions that would ultimately improve the impact of global fund investments. And doing this, we are very aware we have very limited resources. So we bring in different stakeholders, especially the country teams, into these conversations when we are looking at a technical assistance support at the country level. So what can we support? We can support situation analysis and needs assessments. So whether it's a community rights and gender assessments, whether it's a needs assessment, we can support that. Engagement support in country dialogue across the grant life cycle. As we know, country dialogue does not only refer to the consultation period to develop the funding request, but country dialogue is across the grant cycle. So how do we engage in the funding request development, in grant making, in grant implementation, oversight? All of this is part of country dialogue, so we can support community engagement on these stages. Engagement supporting program design and oversight of global fund implementation. So looking at, for example, civil society organization mappings, validating existing tools, or raising awareness of communities on global fund processes and how to engage, these kind of points. And engagement in national strategic plan reviews and development. So these are broader 4 areas that we can support. And when we identify TA support required by communities, we can work together with the Learning Hub, the country teams, our investment support advisors, to really fine tune and hone into what is the exact need that is required, how it is going to complement the implementation of the grant, and going to strengthen and increase the impact of the grant at the country level. So what is included in our technical assistance support through the Community Strategic Initiative? It's a short-term TA. So by that means the work would be, around 3 months. So we will mobilize expertise within 3 months, and we will implement this TA assignment within a 3 months period. We can support expert days of up to 30 days. What does this mean is when we receive a TA request, we would mobilize a team of consultants preferably from the country or from the sub-region, if not from the region. So we are trying our best to make sure that we get consultants' expertise from countries in the region, in Asia Pacific, or from the sub-region. And we will work with TA requester and other stakeholders such as the CCM, the country team, technical agencies at the country level, to work together to deliver this TA to the maximum that we can. And we can also support within the TA some community mobilization activities such as consultations or workshops or validation meetings. The whole idea of the TA is peer-to-peer expertise exchange. So that hence the focus and highlight on getting TA providers from the region. But we also really encourage a combination of senior technical experts with junior national experts. So there is transfer of knowledge and into communities and into advocates. What cannot we support within the TA is CCM strengthening long-term capacity development, such as, salaries for organizations or registration for organizations, developing strategic plans for organizations, things like that. Development of standalone tools. By this, I mean, for instance, if we have a tool that we want to use for CLM in a country and we need a validation or adaptation of the tool for the country, that is something we can support. But for instance, we cannot support the development of a standalone tool for a particular course in one specific country that is not very related to how the Global Fund grants are implemented or to support that process. And we cannot support funding request writing. So for the Asia Pacific region, we can provide about 4 to 6 TA support per year across the 3-year cycle, which is until the end of 2026. Just to give you another idea, so we have 19 technical assistance providers who are pre-qualified and pre-identified. And we also have we will select TA providers depending on the TA requirement from this list, and we can work with the TA provider, TA requester, and other partners to identify who would be the TA provider or providers in terms of the consultants. TA process, what happens? So if you need TA support, you can work with the Learning Hub to identify what the TA support is, and the Learning Hub would be helping you to develop your application. The application could be downloaded through the links that I already shared on the chat. So once we get the TA application, we will do a quick eligibility review. So we will reach out to the country team, investment support advisor. We will look at the alignment of the TA request along with what is happening in the country. And if there are changes that needs to be done, we will work with the Learning Hub and the TA requester to do these changes. Once the TA request is approved and the TOR is developed, and we will start mobilizing TA experts. So we will go to the pre-qualified TA providers. TA requesters can also identify which TA provider they need, and then we will develop the TOR. Once it's developed, it will go through the Global Fund procurement system, and we will start the TA implementation with a kickoff call with all the relevant stakeholders involved, including TA requester, country team, investment support advisors, CRG team, as required. And then once the TA is implemented and finalized within a 3 months period, what will happen is in 3 to 6 months time, we will also do an outcome interview with the TA requesters to see how the deliverables have been used. One of the key points to keep in mind when you're thinking of TA and applying for TA through the Community Engagement Strategic Initiative is we put a lot of importance on the deliverables and how these deliverables will be used to influence decision making within Global Fund and related processes. So for instance, if a deliverable of a TA is to develop an action plan, we really want to know how you are going to use this action plan and in what time framework. It doesn't have to be 3 months, but it can be about, in the next 2 years or in the next 3 years of the grant implementation. At the bottom of this slide, you see the time frame. So after 3 months, 30 expert days, after up to 9 months, we will be doing the outcome interview. So in terms of the human rights related TA that we have supported, these are some of the examples. They are not from the Asia Pacific region, but they're from other regions. So assessing the impact of discriminatory laws, these are some new laws that some countries have introduced around monitoring the operations of NGOs, monitoring the operations of different service deliveries. So, doing assessments on how these laws going to impact the service delivery supported by the Global Fund and other partners at the country level. We have supported, based on these kind of assessment, developing action plans on how to address and adapt community and operations, community service delivery. We have supported a number of community rights and gender assessments One caveat is these are, for instance, if you know the CRG, Stop TB CRG assessment, which is a quite a large assessment, or for instance, in terms of malaria matchbox, these are not the kind of assessments that we will be supporting, because those assessments need much larger resources and a larger time frame. So ours is very quick. We can even say rapid CRG assessments. We have supported a number of safety and security planning. In a number of countries, there are massive safety and security threats that are coming up for key populations and service delivery and things like that. So we have supported analyzing the safety and security context, and based on that, developing safety and security plans. And some other human rights related TA that we have supported is responding to gender and human rights related TRP recommendations. So all this is to provide you a quick snapshot of what is TA, what we can support, and we really look forward for you to engage with the learning hubs, because these TA opportunities are available, and the learning hub is waiting to support you through this process. And from CSI TA, we really put emphasis now on the implementation stage of the grants, given that most of our countries have finished the funding request development. Let me stop there and take any questions that you may have.
Thank you so much, Niluka. As the interest of time, I don't think we can take any question, and I apologize for that. But if you do have question, please feel free to connect with us, and we will be more than happy to connect you with the speakers. And once again, apologize for this inconvenience. Karan, I would like to give the floor back to you.
Thank you, Ika, for moderating the panel discussion, and to all panel speakers. Apologies, everyone, for taking longer than we expected, and also for the technical issues for the interpretation. Now, we will take few minutes to reflect on our webinar by receiving feedback through Mentimeter. So everyone, please scan the QR code or go to the menti.com and use the code which is in the chat box. Next slide. Now, the first question is, what are your major takeaways from this webinar? Just a minute. Just a minute. You can use the code to join the menti.com. And code is in the chat box. I can see any answer.
Aaron, I'm not sure whether it's only me, but it seems I cannot access it on my phone or on my laptop. Once I log in, I only see a QR code. So I don't know whether others are facing the same issue.
Yeah, same thing happened to me, because I log in and I can see only QR code. It won't go inside.
Okay. I think apologize again for these technical issues. we can skip this Mentimeter session. Now, for the final remarks, as we are at the end of our webinar, for the final remarks and the closing, I would like to invite Seri Sarkisia from APNSW, Asia Pacific Network for Sex Worker, as a regional coordinator. Sherry, over to you.
Hi everyone. My name is Sherry. I am the regional coordinator of the Asia Pacific Network of Sex Worker. Again, definitely it's a privilege for me to be here with you all. And to close this, I would like to thank again everyone, especially to the speakers for dedicating their time and energy for this critical discussion, and also on strengthening human rights intervention and advancing the health and well-being of key and vulnerable population in our region. The speakers today from the Global Fund and also from the community has provided invaluable insights into their approach and guidance for human rights intervention as well as personal experience. So again, thank you everyone for sparing your time, and like what Karun has raised, and even in Luca, if there's any follow-up question, you can just drop Seven Alliance an email, and we have our people to respond to it. Thank you, Karun. Thank you all.
Thank you so much, Sherry. I would like to request everyone to open your video so that we can have a group picture at last.
Siapa yang lucu? Muhammad Syah.
One, two, three. One more time. One, two, three.
Thank you so much, everyone.
Thanks, everyone. Bye-bye.
Thank you.
Bye.
Thank you all. Bye-bye.
Bye.
Thank you,
Bye.
Lisa. Bye.
Thank you so much, everyone.
Thank you, everyone. Thank you, Bona.
Bye.
Close.